Good morning, good afternoon, everyone on the call. My name is Mwango Chimundu, a graduate of the Zambia Food Epidemiology Training Program Intermediate Cohort 2. Today, I will present findings from an outbreak investigation on the use of 717 performance assessment for investigation and response to Streptococcus pneumoniae meningitis in Zambia, June-July 2025. Meningitis remains a major public health problem in sub-Saharan Africa. Globally, an estimated of 2.5 million cases and 240,000 deaths occur annually. Most epidemic meningitis is caused by initial meningitis, but Streptococcus pneumoniae can periodically cause outbreaks. As shown on the map, the African meningitis belt stretches from Senegal in the west to Ethiopia in the east, representing areas with the highest outbreak risk. Although Zambia lies at the fringe of this belt, outbreaks are less frequent but still occur periodically, particularly in vulnerable settings. The index suspected case developed symptoms on the 21st June 2025 and was initially managed as a respiratory tract infection in Mwango District Hospital, which contributed to delayed early recognition. A cluster of meningitis-like illness was later identified among pupils at Mwango Secondary School, and the district health office was notified on 3rd July 2025, and this was 12 days late. During this period, 3 suspected cases had already been reported, and none was confirmed. Currently, the alert was triggered based on the clustering outbreak investigation in the northern Zambia with an estimated population of 133,584. The district shares a border with the Democratic Republic of Congo, a setting associated with increased risk of meningitis transmission. All identified cases were epidemiologically linked to Mwango Secondary School, indicating a localized school-based cluster. The overall objective was to investigate the meningitis outbreak and assess the bottlenecks and enablers to outbreak response against 717 timeliness benchmark. On the case definition, a suspected case was defined as any person with sudden onset of fever and other meningeal signs attending Mwango Secondary School or with epidemiological link to the school between June and July 2025. And a confirmed case was any suspected case with laboratory confirmation of Streptococcus pneumoniae from cerebrospinal fluid. We conducted active case search in the school and surrounding communities and reviewed outpatient and admission registers. A standardized line list was developed to systematically capture case information. We collected cerebrospinal fluid samples from suspected cases as part of the investigation. Due to limited diagnostic capacity at the district level, specimens were referred to the regional laboratory, which is 110 kilometers away. Specimens were tested to support etiologic confirmation of the outbreak, and we also followed up or submitted samples to ensure timely feedback. We conducted descriptive epidemiological analysis, and we calculated attack rates for both the school and the district populations. So for school population, the denominator was 1,112, that's pupils at the school, and the district population denominator was 133,584. The 717 framework evaluates outbreak response performance using 3 milestones: detection within 7 days of emergence, notification within 1 day of detection, completion of early response actions, and 7 days of notification. Bottleneck and enablers analysis were done as well for continuous improvement. So this helps identify response strength and system gaps. So a total of 14 suspected cases were identified during the outbreak, and among these, 6 cerebrospinal fluid samples were collected and tested at the regional laboratory, of which 5 were positive for Streptococcus pneumoniae meningitis, confirming the outbreak of the etiology. 1 sample tested negative, however, the case had already met the standard case definition prior to specimen collection and was therefore classified as a suspected case. So the remaining 8 cases were also classified as suspected cases based on clinical compatibility and epidemiological linkage, as laboratory confirmation was limited. The school attack rate was 13 per 1,000 population. The district attack rate was 1.1 per 1,000 population, confirming a localized school-based outbreak with a limited wider community spread. So this table summarizes the epidemiological characteristic of meningitis cases. The most affected sex was the males age 15 and above, and no deaths were recorded in the book. So the figure shows epidemic curve of suspected and confirmed meningitis. Cases by date of symptom onset. So on the y-axis, we have case count, and on the x-axis, we have the date of onset. Blue symbolizes suspected case, red confirmed cases. The first case, identified as the index case, developed symptoms on June 21st. The index case was detected on July 3rd by clinicians, which also marks the point of notification to the district health office. Following detection, the investigation team was deployed on the 5th, and laboratory confirmation was obtained on the 6th. Subsequent cases occurred mainly in early July, with a peak around July 4th and July 6th. This figure shows the distribution of clinical signs and symptoms among the cases, and the most common symptoms were fever, headache, photophobia, neck stiffness, and altered consciousness, which are consistent with classical meningitis presentation. In terms of place distribution, the map shows the distribution of cases in Mwango district. Notably, there was a cluster at Mwango Secondary School. In addition, a few scattered cases were observed in surrounding areas but were linked to the school through day scholars. The slide shows the application of 717 framework and assessment of the bottlenecks and enablers across these intervals. For detection, delayed clinical recognition was the main bottleneck, while clinical mentorship and the availability of standard case definition supported identification. For notification, although there was some initial uncertainty in case classification, a functional electronic IDSR system enabled rapid reporting for early response, limited search capacity, and delays in mobilizing resources were also noted. But timely case isolation, clinical management, strong coordination, and laboratory support enabled a timely response. While delays occurred at the detection stage, the system demonstrated effective notification and response once the outbreak was recognized. Public health actions implemented included isolation and treatment of cases, active case search in the school and surrounding communities, and risk communication among pupils, teachers, and community members. Healthcare workers and teachers were oriented on meningitis signal detection and capacity building in lumbar puncture, sample collection. Techniques was also conducted to improve diagnostic readiness. This outbreak mainly affected school pupils, indicating a school-based cluster with epidemiologically linked community cases, with the majority of cases among adolescents consistent with school-based transmission. Meningitis outbreaks are commonly reported in the district, and delayed detection suggested delayed clinical recognition. Misclassification reflects gaps in frontline diagnostic capacity. However, notification and early response timeliness were achieved, demonstrating strong district response capacity once the outbreak was recognized. These findings highlight the need to strengthen clinical suspicion and early recognition of uncommon public health actions. I would like to acknowledge the following institutions for their contribution to this work. Thank you very much.